Good morning and welcome. I'm Roger Mark D'Souza, and I direct our programs on reproductive health and maternal health here at the Wilson Center, including our maternal health initiative. And I have two sons. They're no longer adolescents. They're now 21 and 23. But I do remember when my oldest son was an adolescent, sitting down with him and saying, okay, we're going to have a talk again. And he looked at me and he's, Dad, are we going to talk about sex again? And he ran down the stairs far away from me. So yes, we're going to be talking about sexual, reproductive, and maternal health of urban adolescents and youth in the city. And I'm really glad that you joined us. You're here with us early on a Monday morning, on a holiday week, to address such an important topic. It really demonstrates your commitment and interest in this topic. And we at the Wilson Center, as many of you know, serve as the living memorial to President Wilson, established by Congress. And we see the issues of reproductive health and rights and maternal health as being critical to the mission of the Wilson Center. You know, very often I'm dealing with colleagues who are looking at key development priorities, security, conflict, peace building, and we come in and we say, let's talk about youth and the city and reproductive health and maternal health. So we see this as an important opportunity for us to make connections to a broader development agenda. And we're particularly pleased when we can do this with colleagues like Save the Children. Save the Children makes us look good. So thank you. This is the third in a series of important conversations that we have been having on these topics. So I'm really pleased that we have a superstar panel with us this morning, and I'm going to hand it over to Lanny Crane. Lanny is going to be moderating today's discussion. And Lanny serves as a technical specialist in urban health at Save the Children's Department of Global Health, and she supports the country offices working on urban health strategies and helping us understand through documenting those programming. She also supports the portfolio of work around child sponsorship funded programs and is a member of the team that helped produce SAVE's 2015 State of the World Mothers Report, The Urban Disadvantage. So Lanny, welcome to your second home here in Washington, D.C. We're delighted to have you, and I'll hand it over to you.
Thank you so much. As Roger Mark mentioned, this is the third in a smaller series that we've been doing in partnership with the Wilson Center and the Maternal Health Task Force, focused on urban maternal and newborn health. And we had spoken previously in our first event on a general overview on urban maternal and newborn health. We spoke in our second event about meeting the needs of displaced populations in terms of maternal and newborn health in urban settings. And today I'm delighted that we'll be speaking about urban adolescents and youth, and specifically sexual, reproductive, and maternal and newborn health related to adolescents and youth in cities. So why are we talking about this? We know that more than half of the global urban population is under the age of 25. And what that really means is that meeting the needs of global cities is inextricable from meeting the needs of newborns, children, adolescents, and young people. As the world is globally urbanizing and we see that there's rapid growth in cities and young people moving to cities for economic opportunities, it is clear that cities have a critical role to play in ensuring the health and well-being of their populations, and also ensuring that we're able to achieve global goals like SDG 3 and other commitments. Cities have a number of advantages for girls and boys. It may be economic opportunities, but also being in cities may provide at least geographic access to health and education services. But we also know that living in cities comes along with some significant risks, and that geography does not ensure access. In many urban settings, adolescents and youth must contend with the threat of violence, gender discrimination, a lack of access to quality health services, and limited family and social support. Adolescent girls in cities face a greater risk of being coerced into having sex than their rural counterparts. And the poorest urban girls ages 15 to 19 are 3 times more likely to become pregnant than the wealthiest in urban settings. And we know that adolescent girls face particular risks with regard to maternal and newborn health. Adolescent girls are more likely to die from pregnancy-related causes than women in their 20s, and they are at increased risk for preterm birth compared with women ages 20 to 35. Their newborns and infants also face a greater risk of mortality. So at Save the Children, we have been working extensively in adolescent sexual and reproductive health and also in maternal and newborn health with programs in more than 20 countries. Recently, we've expanded our work into urban contexts, recognizing that in this era, in the age of the city, some of the poorest and most vulnerable are actually located in urban settings. We're excited to bring you this panel today to shed some light on the experiences of adolescents and youth in urban contexts, share a bit about the types of programs that can reach them, and some lessons learned from programming and research in urban settings. We recognize that adolescents and youth are not by any means a homogeneous group. They have extremely different needs by age, life stage, and other variables. And we structured our panel so that each one of the speakers will focus on a particular age and life stage of adolescence and youth. So we have our first speaker who will highlight the needs and programming approaches for very young adolescents, ages 10 to 14 in urban contexts, and we'll use as an example a program in urban Democratic Republic of Congo. Our second speaker will describe a program in urban Rwanda that uses human-centered design to learn from and design with older adolescents. And our last speaker will share research findings examining quality maternal care for adolescents and youth. So we'll have each of our speakers go through their presentations, and then we'll have a small moderated discussion with the panel, and then we'll open it up to all of you for questions. And as with our previous events in this sub-series, this is really an opportunity for discussion on an emerging area. We want this to be a space in which you feel that you can share your comments and your experiences as well as your questions. So we look forward to that. And I'd like to invite up our first speaker. Melanie Yonner is a senior specialist in sexual and reproductive health with Save the Children. Melanie provides technical assistance to Save the Children's adolescent sexual and reproductive health and family planning programs. She focuses on programs for very young adolescents and first-time and young parents. She has a master's degree in public health from Columbia University, a bachelor's degree from the University of North Carolina at Chapel Hill, and over 12 years of experience in technical assistance, program management, and monitoring evaluation for SRH programs in Sub-Saharan Africa, South and Southeast Asia, and Latin America. So welcome, Melanie.
Thank you, Lonnie, and I'm excited to be here, and I'm excited to see that so many people were able to come out on a Monday morning. So as Lonnie mentioned, I will be talking about some of Save the Children's experience with programs for very young adolescents. And I should note that we started a lot of these programs in rural settings, and we faced a lot of challenges and learned a lot from adapting to an urban context. And I'll talk a little bit about some of those challenges and the lessons going forward. So first, a bit, how do I advance this slide? Sorry. Okay, well, maybe if you can just advance, I'll tell you when to advance. All right, so we'll go to the next slide. And first, I'll start with a bit of context about why we focus on very young adolescents. So this refers to the ages of 10 to 14, and from here going forward, I will use the acronym VYAs. So during this critical transitional period, we see a number of changes on the biological, cognitive, and socio-emotional fronts that really make this an important window of opportunity. So on the biological front, we see the onset of puberty and the physical changes that mark the transition from childhood to adulthood. On the cognitive front, adolescents become capable of higher level thought and higher level decision making. But we also see that adolescents may tend to rely more on emotions and instinct for decision making than adults do. And these changes happen in roughly the same way regardless of where adolescents live. But while these changes are taking place, adolescents are transitioning into a new role in society, and they face expectations that they'll act like men and women rather than as children. And one of the major elements of development that happens during early adolescence is the formation of social norms, which are the rules that govern our behavior based on what we believe that most other people do and based on what we believe that most other people expect that we will do. And this aspect of development will vary based on residence, as it's really driven by the norms that are held by the surrounding community. So early adolescence is really a critical time to lay the foundation for healthy and fulfilling sexual and reproductive health lives. But this age group tends to be chronically neglected in health policies and programs. So most policies and programs either focus on younger children under the age of 5 or older adolescents over the age of 15. Slide. So to address the needs of adolescents, of young people during this critical period, next slide. Thank you. So to address the needs of young people during this critical period, Save the Children has been developing approaches for VYAs, and we include a number of different elements with the overall objective of building foundations for gender equitable practices and use of health services, including contraception, when adolescents transition into the later years of adolescence and potentially become sexually active. So our VYA programs use an ecological approach to engage the multiple spheres of influence that shape VYA's norms and practices. So we include activities with their parents and other adult caregivers. We engage their teachers when they're in school. And we have activities with other community members. And then we foster linkages to the health system, again, for future use. And because gender and social norms are really formed and solidified during this period, we encourage the formation of positive gender norms. We focus on comprehensive sexuality education, so making sure that VYAs have age-appropriate information about puberty, fertility, sexuality, and contraception. And we do this in fun and interactive ways, so using stories and games. And we focus on building local capacity, which means implementing simple, scalable interventions and implementing through local partners. Next slide. So I will focus on an example of a project that Save the Children is implementing with VYAs in Kinshasa in the Democratic Republic of Congo. And this work is funded by USAID and the Bill and Melinda Gates Foundation and under the Global Passages Award that is led by the Institute for Reproductive Health at Georgetown University. And we've partnered with the Global Early Adolescent Study, which is led by Johns Hopkins University, to do a longitudinal evaluation of the work. So this is a 15-country study that's looking at the formation of gender norms among urban adolescents, 10 to 14. And so this is a really exciting opportunity to look longitudinally at the outcomes of intervention in early adolescence as our participants transition into the later years of adolescence. And this project focuses on adapting an approach that we developed in northern Uganda in a very rural context to the urban Kinshasa context. And that project was called GREAT, Gender Roles, Equality, and Transformations. And so this iteration is called Growing Up Great. Next slide. So first, a bit about the context in which we're working. So Kinshasa has an estimated population of between 10 and 12 million people. Estimates from 2007 tell us that about 12% of VYA girls and about 9% of VYA boys are out of school. And as adolescents, in the later years of adolescence, we see that this gender gap becomes more pronounced. So about 1/3 of girls 15 to 19 are out of school compared to about 1/4 of boys. About 11% of girls have had sex by the age of 15, and about 13% will have started childbearing by the age of 19. And only about half of VYA boys and girls live in a home with both of their parents. So within this context, Save the Children is implementing a program in just a subset of the neighborhoods in 2 of the 24 communes of Kinshasa. Slide. So as we prepared to launch the intervention, we did some asset mapping, and our partner, Johns Hopkins University, led a rapid assessment. And some of the information that we found really challenged our assumptions that we would find more existing structures and more capacity on which to build in an urban area. So first, we looked at school enrollment among VYAs in these supported areas, and we found that in Kinshasa, the situation is complicated. So school enrollment tends to be highly fluid. And it's common for children to leave school temporarily as their parents are unable to pay school fees or as they have to generate income for their families themselves. So as a result, you have children who have to stay out of school for part of a school year or a full school year or even more. And as a result of that, it's common to find 13 to 14-year-olds who are in relatively early grades of primary school because they've missed so many school years along the way. And so in order for us to reach the VYAs, we've had to kind of cast a wide net in terms of the schools that we work in and the grade levels that we target to reach those 10 to 14-year-olds. And another thing that we learned is that a lot of these schools are actually operating 3 school days in one. So they're running a session in the morning, one in the afternoon, and one in the evening. And as a result, the classrooms are overcrowded, the teachers and school staff are stretched, and it's really difficult to find opportunities to hold any kind of after-school activities because that concept doesn't really exist. The space is not available. And then we found that there are multiple different types of school that include those that are public, private, and those that are affiliated with a number of different religious denominations. And the fees are highest in the private schools and in the public schools that are religiously affiliated. And so we found that the most vulnerable students who are in school tend to be in the public, non-religiously affiliated schools. Most of the schools are very close to health facilities, so it provides good opportunities for linking with the health system for future use of health services. But we found that the existing health services don't meet minimum standards for safety and quality, and that they suffer from pervasive stockouts of contraceptives and other essential supplies and equipment. And then we found that there are few providers who had been trained to provide a full range of contraceptive methods, and even fewer who had been trained to provide adolescent responsive health services. And overall, we found relatively few platforms on which to build. So very few of our intervention schools had established clubs, and so we've ended up forming our own clubs of participants for our intervention. And then while urban areas may have more community-based organizations or CBOs, we found none with expertise working with VYAs, which is not surprising. And we found few with experience working in SRH in general. So, next slide. So under Growing Up Great, we're aiming to transform key gender-related norms related to education, violence, discussion of puberty and sexuality, and health service seeking by adolescents. So Growing Up Great uses an ecological approach. So to reach VYAs themselves, we've established mixed sex groups within schools, and we reach a different set of VYAs who are not currently enrolled in school with community groups that we have established. And so within these groups, we're using a set of interactive materials to encourage VYAs to discuss and to reflect on norms related to gender in particular. And then we also recognize how important parents are in shaping the perceptions and the behaviors of very young adolescents. So we developed a set of video testimonials that actually feature parents from these very same neighborhoods who have adopted the positive practices that we're trying to influence. And we invite the parents and the other adult caregivers of our VYA participants to join discussion sessions that feature these videos. We've worked with teachers and school leadership to incorporate the materials into the classroom setting to complement the National Family Life Curriculum. And we're challenging norms related to the use of health services by adolescents by inviting health workers to give a session within the clubs of VYAs. And then we facilitate an exchange visit where we actually have the VYAs go and visit the local health center. And then finally, we engage members of the broader community through an adult version of the game that's played with VYAs, and then through those same video discussion sessions. And the intervention was really designed to be as simple and as scalable as possible. So the activities are all implemented through local partners. The school group sessions are facilitated by VYAs themselves. And ultimately, we're really trying to see how effective a light touch approach can be. Next slide. So we made a few major adaptations from the rural northern Uganda context to the Kinshasa context in the design phase. So we know that when we're talking about urban work, we need to really reframe how we define community, and that often our mental frame for community is a rural setting. So instead of using a radio discussion approach, which we had used in Uganda, we really focused on reaching the parents and the adult caregivers of the VYAs themselves, because we know how important parents are in shaping the attitudes and the norms of VYAs. And then we also, as I said, play the game, and we have video discussions with community members more broadly. And we found that the adaptation of the materials to the Kinshasa context was relatively straightforward. So the images took on a much more urban look and feel, with cinder block homes and courtyards instead of huts in a rural village. And now, instead of gathering firewood, the main female character throughout the materials fetches water from a communal tap, and she does her chores in her family's courtyard. And then we also made a number of changes to adapt the materials for out-of-school youth. So the rapid assessment had found that girls in particular, especially those who are out of school, don't spend a lot of time away from home, but when they do, church and the market are common places for them to spend their time. So the characters in the material spend their time at home or in church or in the market instead of in school. And then we also noted that a lot of out-of-school youth in particular are not living with their parents. And so many of the references to family were revised to include aunts and uncles and grandparents. And then we revised the future aspirations to be realistic for young people who are not in school. Slide. So over the last couple of years, we've adapted our materials and we've now launched our activities. And we've made a lot of progress, but we've faced a couple of challenges in doing so. And some of those challenges really are specific to working in the urban setting. So at the individual VYA level, we've been dealing with a lot of gender-related challenges in ensuring the equal and active participation of girls. So girls in particular tend to have a lot more restrictions on their movement around the community, in part due to safety concerns and also because they tend to have more responsibilities at home, such as doing chores and caring for younger siblings. And so as a result, we're seeing that girls in particular tend to miss more sessions, and often when they do come, it's with younger siblings in tow. We've also experienced challenges in forming the groups to reach out-of-school youth, because when we did the mapping, we didn't really find natural existing platforms to do so. So we ended up working through a network of community child protection volunteers that Save the Children had previously formed, and they identified families who had a VYA who was out of school. And in other contexts, I should note that we've approached this by looking for informal groups of children who are out of school, like Boys Who Shine Shoes. And we've also experienced, in the busy urban context, we're finding that parents are often busy working multiple jobs and they're kind of dispersed across the city. And so it's really difficult to find days and times that work for their schedules. And then it's especially difficult to encourage fathers and other male caregivers to participate in the sessions, since many of them don't live with their families, they're working multiple jobs, and often they're not even able to live in Kinshasa. And in the urban context, there are a number of competing options for adults' very limited free time. And so a discussion featuring video testimonials may not be as interesting or as attractive as it may be in a rural setting. And through this and through other projects, we're finding that teachers and students in urban contexts often start with higher exposure to SRH information to begin with. So they're getting information from the media, from the community, from social media, and even from pornography. But the information that they have is not necessarily accurate, and it's not necessarily positive. We've found that, as I said, there are multiple types of schools, and each type poses a unique challenge for implementation. So certain religiously affiliated schools may be reluctant to allow discussion of SRH in general. The private schools have owners who are seeking to turn a profit, and so that requires a different type of engagement and a different type of advocacy to ensure their buy-in to allow us to work in those schools. At the health system level, it's interesting to note that when we did that mapping, we found that the schools are on average 100 or 200 meters from the closest health facility. So physical access is not a challenge in the way that it is in rural settings. And often the closest health facility is literally just around the corner. So you're not contending with a challenge of needing to find time and resources to manage travel to a distant health facility. But this physical proximity may actually pose a different challenge for adolescents, because we know that for adolescents, one of the most important factors for seeking health services is being able to do so discreetly without others in the family and the community knowing. And so as a result, this very close proximity to health services may result in adolescents not being able to use services as discreetly as they would like. And at the community level, we're finding that neighbors or that parents are heavily influenced by their neighbors. And mothers in particular talk about being strongly influenced by what their female neighbors might oversee or overhear and how they would judge what they see. There's really not a lot of space or privacy, which kind of results in this intense pressure and a fear of being caught doing something that others wouldn't approve of. And so this makes it hard when we're trying to challenge norms and we're trying to encourage parents to adopt behaviors that are different. But it could also have be a positive factor when it comes to diffusion of social norms, as new trends can spread quickly in a setting where everyone knows and everyone is influenced by what others around them are doing. Next slide. So as I conclude, and the point I'd like to leave us with is, we need to challenge ourselves to think holistically about how we define the needs of poor urban adolescents and how we make sure that they have hope for their future. So we know that the ability to delay pregnancy until adolescents are physically, emotionally, financially ready is a key component of keeping adolescents in school and helping them to achieve their dreams for the future. So we know that SRH interventions are critical. But we also have to think about how to give young people a viable alternative to early childbearing. And this needs to come in the form of education and livelihoods opportunities. And we especially need to think about what that hope for the future looks like for the young urban poor who are not currently in school. And as I said, this means SRH interventions are critical, but it may mean that SRH interventions need to be delivered as part of a holistic program that is making sure that we're addressing the very basic needs of housing, education, sanitation, and just basic protection from harm for very young adolescents. So I'll stop there. Thank you.
Thank you, Melanie. I'd like to invite up our next speaker. Nicole Ippoliti is a design strategist and adolescent sexual and reproductive health specialist at Y Labs. Nicole brings extensive experience in designing and implementing global adolescent programming focused on behavioral and social norm change. Her area of expertise includes sexual and reproductive health, HIV, and digital health. She's lived and worked in Central America, Southeast Asia, and Sub-Saharan Africa. Nicole has a Master of Public Health from the University of North Carolina Gilling School of Global Public Health. Welcome, Nicole.
Thanks, Lonnie. I'm really honored to be here today and share a little bit about our program, Cybergirl Rwanda, which aims to reduce teen pregnancy and unemployment among urban Rwandan youth using a human-centered design approach. So I thought it would be helpful to begin with a very quick primer on human-centered design. Human-centered design is a creative approach to problem solving that starts with a question rather than a solution. It's a deeply methodological process that seeks to design solutions that are really driven by user needs and insights. And from those insights, we can start to build tangible, testable versions of low-fidelity prototypes with users to get their feedback and refine solutions before we move to implementation. A little bit about some context about where we work. So through Y Lab's previous work with youth in Rwanda, we knew that access to technology was skyrocketing among young people. Yet despite rapid economic development, many Rwandan youth were being left behind. For girls, there's been little change in teen pregnancy rates, increasing HIV infection, and unemployment is highest among urban girls. So we asked the question, how might we leverage technology to address teen pregnancy and unemployment among urban girls? So over the past year, we've been designing the program in partnership with Rwandan youth and their communities. Using a human-centered design approach, we've run multiple interviews and co-design workshops with over 400 youth, parents, healthcare providers, community leaders, teachers, and employers. And early on, we learned a lot, not only about young people's sexual health needs, but also the broader reality of their lives, their dreams, their aspirations. And this really became the foundation of our design. So all of this design research gave way to 5 major insights that really shaped the direction of our design. And the first is that sexual education in school is largely limited to condoms and abstinence. And we found that existing materials were really based on scare stories of the negative consequences for teens who had sex without giving any practical information about how to access contraception or how to use it. Similarly, we found that healthcare providers felt that their main role was to keep young people abstinent and not provide them with any kind of contraceptive services or counseling. And providers were also heavily biased against hormonal methods and the types of girls who would really qualify for them. Next, we found that talking about contraception is taboo. Also, talking about sex is heavily taboo. So girls and boys needed a private, trusted source of information for sexual health and family planning that would also be acceptable to their parents. And we also learned that young women had shockingly low knowledge about their bodies and puberty, regardless of age or socioeconomic background. So it's an interesting dilemma, because when young women don't know what their periods are, it becomes extra challenging to explain contraception or how to use it. And as a result, we really learned that our health curriculum needed to go beyond contraception and HIV and actually take a step back to include lessons on puberty and menstruation. Having the skills to get a safe and lucrative job is important not only to youth, but also to their parents. And because of this, we decided to take an integrated approach in our programming by contextualizing pregnancy prevention as a means towards ensuring the potential for entrepreneurship. And so by framing the program in this way, we were able to get parents to agree to more comprehensive sexual health education as a gateway to safeguarding their children's economic futures. Finally, boys. All stakeholders we talked to, including boys themselves, emphasize the need for young men to have more accurate information about sexual and reproductive health. The stigma of discussing sex and contraception if you are unmarried is just as real for boys as it is for girls, and they were often seeking information from unreliable or illicit sources, as just like porn. I think, Melanie, you mentioned the same thing. So based on these learnings, our programmatic aims were to deliver trusted, accurate, and confidential sexual and reproductive health and education that both met the needs of girls and is also acceptable to parents, build youth financial capabilities, and establish a referral network to youth-friendly providers. So I wanted to share a little bit about our initial design, and this is sort of what it looked like. It was a mobile app that is simple, heavily white and pink, and incorporated both job skills as well as an avatar, Juliet, who would direct youth to a clinic or answer any questions youth had about health. And we learned several things very quickly as we started to prototype. First, combining sexual education with employment skills did, as we expect, make it more acceptable to parents and more interesting to youth. Health is not always at the top of their mind, but their financial education and their financial futures certainly were. We also learned that this prototype in this iteration and design was not going to work. The design didn't look and feel Rwandan. White is associated with death in Rwanda, which is not exactly the message we were trying to convey. We needed something more visual and vibrant. The virtual nurse character looked like a peer, and you said that they needed someone to whom they could aspire, someone who looked more professional. The content was not exactly aligned with what they wanted to know. And most importantly, having a very refined and polished prototype like we did, this mobile app, really inhibited their honest feedback about what they were really looking for. So these learnings led to a really critical turning point for us, for the program. We knew that we could not proceed forward with what we had, knowing that the content and design did not resonate with our users. So we decided to start over and design with youth. So over the course of this past year, we've been using these paper dolls, which have been really interesting. It takes about a couple hours to make. And the girls, we went to the market with the girls and we picked out fabric. And it really helped us to understand sort of what the girls are looking for, who do they respect and look up to, what would that person look like, how would she talk to girls, what was she called. And early on, one of our youth designers renamed our peer educator, and she suggested the name Mutoni, which means one who is precious. And so we took scraps of fabric to get an understanding of what colors and designs appealed to girls. And then these fabrics were then digitally scanned to dress Mutoni, our virtual peer educator. And then from there, we could start to build on more realistically Rwandan characters and test them with youth. And testing on paper really allowed us to rapidly iterate and refine ideas at a low cost and low risk based on what young people told us. So we shifted the design from very white and pink to something a little bit more vibrant. I just wanted to show sort of the progression of the avatar Juliet to Mutoni. Again, so the first picture is the nurse avatar. And you see that we sort of left her blank. And then based on feedback, girls had said that they wanted someone who was a little bit older than them, someone like a cool auntie, and that they didn't want a nurse, they wanted a peer educator. So then we have this. And then they said they wanted someone who looked really more professional looking. So they wanted a cool auntie who is a little bit older than them and someone who's professional. So that's how we came with Mutoni, and this is our final design. So now that we had the design and the basis of the content, we were better able to determine the program structure. So it has 3 components: the Teen Guide to Success, which is developing digital and printed education tools on sexual and reproductive health and employment job readiness. The second is to deliver trusted, accurate reproductive health information and referrals via SMS and IVR. That's through Baza Mutoni and Baza Natwali. And then we have Cyber Nurse, which is we're creating digital support tools for service providers to improve their knowledge on sexual reproductive health and address provider bias. And these are sort of our anticipated outcomes, which have to do with improved knowledge, skills, self-efficacy, and access to reproductive health information and job readiness resources. And then on the provider side, we have improved quality of services by improving provider knowledge on youth sexual reproductive health and again, addressing their biases. So this is what's next for CyberGirl Rwanda. Next year in January, we're going to start working on building digital support tools for service providers. We're going to move from prototyping, which we've been doing this past year, into actually developing the digital and non-digital solutions for young people. And in 2019, we'll be looking to evaluate the program. So I wanted to leave you with a couple of points about why this experience matter. And I think that if there's one thing that you walk away from this presentation with, let it be this. We really need to engage young people in the design and implementation of adolescent health programs. We believe that human-centered design offers a creative and deeply participatory approach towards co-designing and prototyping with youth for better program design and more tailored solutions. Human-centered design takes the risk out of designing solutions for scale. We developed confidence and tested our assumptions with over 400 beneficiaries and key stakeholders before we even launched. We shifted massively from our original idea. It's important to test assumptions and be open to failing and pivoting rapidly based on what you learn from your users. It will make your program stronger. And then the last is that we need to start designing programs with a question rather than a solution. To design for this generation of young people whose needs are rapidly changing, we need to work in partnership with them, understand their needs and aspirations, and involve them deeply in the design and implementation of health and development programs. I just wanted to close by thanking all of the young people who helped make this program possible, and our team who worked to design this program, and special thanks to our donors, the Packard Foundation, for believing and funding this work.
Thank you, Nicole. So we'll move on to our last speaker now. Pooja Shripad is an associate in maternal and newborn health with Population Council. She is a mixed methods and qualitative researcher using critical approaches to understand how trust and socio-political relationships affect reproductive and maternal health. She has experience in urban health and has worked in varying capacities with the Population Council over the past 4 years, including on the Hashima, Link Up, Fistula Care Plus, and Ending Eclampsia projects. Pooja holds a PhD in International Health Systems from Johns Hopkins University, an MPH from Yale University, and a BA in Public Policy from the University of Chicago.
Well, thank you all for being here today, and my co-panelists. It's an honor to be able to present some of this work. The presentation that I'll be giving is a little bit more to present some research findings that we came out of a larger implementation research project, and it'll focus a little further down the life course on the experience of adolescent mothers and their male partners, as well as drawing on the opinions of providers that have seen a number of adolescents giving birth in this particular peri-urban context. Just as a sort of broad summary, we'll be looking at the role of trust in the care-seeking pathway in peri-urban Kenya. So I thought I would just start out by giving a bit of a sort of what we know about adolescent maternal health. Globally, we do know that young people have unique experiences of pregnancy and childbirth. We know that from the literature, there's not that much, but that we do know they have less access to information relating to maternal health and family planning services. However, there's quite a bit of variability when it comes to access to this information, both across countries and within particular country contexts. So, for example, we already heard about wealth differentials having an impact. We heard about socio-cultural norms, socioeconomic status, schooling. All of these have an impact on how much information women have, the quality of that information, and how they're able to use that information to seek the services they need. We know, for example, in Nigeria, sociocultural norms and socioeconomic status play a significant role in predicting access to antenatal care, skilled birth attendance, as well as postnatal care among married adolescents. We also know that in Bangladesh, a prospective qualitative study showed that household gender dynamics affect decision-making capacity with respect to maternity care seeking. So moving to Kenya, we know that women under the age of 20 are sexually active and are having children quite regularly. And what's interesting about this 18% is that it hasn't changed very much from 2008, meaning that this group still needs to be understood better, and we need to understand what they need in terms of their health care. We also know that although quite a few women are able to get at least one antenatal care service, this falls out when you look at the continuum of antenatal care. So the quality varies. Some women only have one visit, while only a few have all 4 or more visits for antenatal care service. So moving on to trust as a concept. We all know about trust. We all understand trust in different ways. But basically, it is a belief that one's expectations will be met by another individual or a system. So in the context of healthcare settings, this could be between patients and providers, and that's a number of providers that they may encounter in a health facility. It could also be between a woman, say, delivering, and the overall facility capacity. So this may include things like drug supplies, equipment, and overall reliance on the facility to be able to give them care in an emergency setting. The concept of trust is interesting in that it offers insight into relationship quality. So really gets at the ability to understand interactions, how power dynamics affect the perceived experience of care, as well as to unearth inequities in health experience. So the Hashima project was conducted in Kenya starting in 2010. It was funded by the USA Translating Research into Action project. And so this work looked to understand what was going on with disrespect and abuse in central and western Kenya, and to design through a participatory approach interventions to promote respectful maternity care. So during this process, we learned that about 20% of all women were in these locations were experiencing some form of disrespect and abuse during their maternity care. We also learned that trust as a concept kept emerging in some of the interviews that we conducted as a particularly interesting area of research. So with that, we conducted a more in-depth study to look at this concept and how it may be affecting care-seeking decisions. We found in Kenya that trust is nested within broader understandings of trust in social institutions as well as general societal trust. And as you can see, I don't know how to use this. As you can see, trust in maternity care really includes trust in providers, in the health facility, in community health workers, as well as workplace trust. And for the purposes of this presentation, I'll primarily focus on trust in providers and facilities, as we learned from the adolescent perspective. And finally, just to show that trust is actually a multidimensional concept, and the highlighted words here reflect some of the themes that came out of the adolescent work. So the study setting for this work was in central Kenya. It was a peri-urban county, and that included both a sub-county hospital as well as the surrounding communities. The county itself had a highly inequitable wealth distribution, and these populations that we talked to, both what was interesting about the peri-urban context is that they're fairly close to the urban setting, so they have some options, but not as many as maybe someone who's located in the center of the city. But their socioeconomic capacity are more similar to their rural counterparts. So we used a qualitative approach to understanding this concept. We conducted focus group discussions with a range of participants that included both those who had experienced pregnancy and childbirth or those who were pregnant for the first time. We also included male partners of women who were delivering in facilities to understand their perceptions of care and what they felt would be good for their partners. And we, as you can see, spoke with health facility providers as well. The adolescent sample that we had was diverse in some ways. They had a mixed level of schooling, so some had primary schooling and some had secondary. But what's interesting is that all of them had some level of schooling. About 42% were single, so unmarried. And in terms of occupation, there was a distribution between about an even distribution, 35% between those who were engaged in farming-related activities, those who were self-employed in small businesses, and those who were unemployed or homemakers. This group also had between 0 and 4 children. So you can see that women are having children quite early. And interestingly, some of these women who had delivered in facilities are now considering or rethinking whether they want to continue to deliver in facilities for their next birth. So that's something that's important when you think of antenatal care or delivery care being often the first point of contact for young women. So although this study did not focus specifically on adolescents, through the work on trust, we were able to really delineate and find some insights around the key issues that our adolescents are facing in this peri-urban context. So as you can see here, there's sort of a range in terms of normalized care seeking, as well as sort of differential experience in birth preparedness. There's also different preferences for types of providers or those that the adolescents would like to deliver around. And the various ways in which provider prejudice and communication between patients and providers affect the quality of care that young women experience. So to give some examples from the voices of young people themselves, we know that young people generally accept skilled birth attendants as necessary for their maternity care, which I think is kind of example of a shift in maybe what we thought before, and that young people do trust often, just as a default, the providers that give them care in the context of maternity, both during labor and delivery and at the antenatal care stage. Trust is, as you can see, both in the context of providers as well as the facility. The first example gives actually an example of a woman who had a cesarean section after suffering a range of complications. And the second really shows that the dialogue and the mutual respect afforded in those dialogues are critical. And the final one shows that antenatal care and the trust relationships that are built in that setting really do affect whether or not women decide to seek care for their delivery. So in this context, a woman was describing how she enjoyed being explained what her blood pressure was, as well as what her baby's heart rate was. All these types of information were given during her care experience. We found that trust networks and relevant communication channels were important to tap into when it came to birth preparedness for adolescents. So parental figures or formal health messages were often preferred, as described by our sample, as opposed to peers. So some did speak about learning from their peers when it came to what to do during childbirth, but they also seemed a bit skeptical, which I think is interesting from some of what we've heard in terms of how who the people are for passing along information at different points in an adolescent's care seeking. So they also mentioned that radio and television were important sources of information, particularly on where to deliver. So if a facility had a negative reputation, they may not want to deliver there. And finally, the group antenatal care model emerged as a particularly important space for young women who were single. So thinking through those who do not have support systems is particularly important in urban contexts. So the other, another interesting point that came out of our research was that adolescents in this context preferred certain older female providers as well as male providers because they felt that they were more empathetic. We heard a lot about, for example, motherly figures or being treated like a doctor or a sibling or something like that, and that was preferred when it came to actual labor and delivery. Interestingly, we also heard from males that they preferred that their wives preferred to deliver around or labor around women of similar age groups instead of being with, as someone mentioned earlier, like a much older person who maybe had a judgment about why this young woman was pregnant. So that definitely came out. And there was a preference for birth companions. And interestingly, this is from a male focus group to show that there's really a need to engage men and boys from a young age around sexual reproductive health issues, but also at the time of delivery wanting to be a part of that process. We also found that age affects the level of disrespectful or respectful care afforded to all women, but that for adolescent pregnancy and childbirth, adolescents often garner a mix of provider prejudice as well as sensitivity. So on the one hand, providers may be judgmental, and that judgment may affect how they interact and how they speak with the women that they're serving. But on the other, they may be more attentive to providing women sort of the full process of care, given it was their first time delivering a child. So that was interesting to see. And in the peri-urban setting, there were definitely some issues that have already been raised a bit. Unplanned pregnancies came out as particularly affecting adolescents, same with rural to urban migration, and the nature of intimate partner relationships, all of which sort of act together and affect access in peri-urban settings. all of these factors also increase the risk of young adolescents, as well as restrict their care seeking in unique ways. And we can see that from these examples here, that teen pregnancy was rampant in this, well, rampant, it was quite prevalent in this peri-urban context among both married and unmarried girls. And this, the fact that many of the pregnancies were unplanned led a number of women to hide their pregnancy, and that in turn meant that they weren't communicating openly with providers. So sort of this surreptitious or sort of secrecy around pregnancy was a real challenge for both the provider perspective, and we'll see a little later from the woman's perspective as well. And these vulnerabilities, as you can see, migration really affecting it, and finally, the sort of dynamic or short-lived relationships that might affect in urban settings. So we also found that communication played an important role. As you can see here, this first quote really speaks to a 16-year-old's, a medical officer who was treating a 16-year-old who hadn't fully disclosed her status, and that led to some mismanagement and delays and sort of potentially a negative perceived experience of care. We also see that among unmarried women, again, there's a challenge about disclosure that we really need to think about when it comes to adolescence. And finally, the sort of from this perspective, we see when a doctor isn't speaking to you nicely, that will make it difficult for you to tell the doctor your problem. And so the hesitance to disclose information may be particularly high among certain subgroups of adolescents. So just to step back, I thought I would put up a model that kind of describes the themes that had come out of our adolescent work. And we see that adolescent trust is an intermediate factor in the care-seeking pathway along the full spectrum of antenatal, maternal, and postnatal care. So past experience or a lack thereof may affect how they feel, how they trust a maternity setting, and that in turn may affect their future intention to seek care. And we see this is affected by certain attributes of both the adolescent mothers, their partners, as well as the providers. And finally, the peri-urban context in which all of this is happening has implications for the full care-seeking pathway. So I just wanted to end with a couple of reflections. Given this area, there's still quite a bit of need to do more rigorous research in this space. I think it's important that we think about young people's pathways to care and understand that these are dynamic and changing, and we need to see how one point of contact affects the next if we want to make sure adolescents are using health services to their benefit. We also need to think about complications in pregnancy. As we heard earlier, preterm birth and experiences of sort of adverse outcomes in both maternal mothers as well as newborns. Our adolescents are particularly susceptible to these, and so we need to think about how to address those issues, and also see how urban and rural settings vary. So I think there's quite a bit of work in rural settings. Still more could be done, but I think to really understand the differences and the unique intervention needs in both contexts. And then finally thinking through what the networks are, what are the channels of communications to effectively reach adolescents, particularly those who are unmarried and maybe have a more vulnerable status in the peri-urban context. So with that, I'll just thank you all and look forward to an engaging discussion.
Okay. So thank you to our panelists for their excellent presentations. I have a few questions for the group, and then we'll open it up. So one thing I think came out very clearly, obviously when we're talking about urban adolescents, we're talking about a particularly heterogeneous group, and the way the discussion was structured, we had, differences by age and life stage. But as we were talking, I picked up on a few different types of adolescents living in urban areas and was hoping you could comment a bit further. One group I know that came up in Melanie's presentation was in-school youth and adolescents versus out of school. From Pooja's presentation, we heard about, peri-urban as compared to those who might be living in a city center, but also the differences faced by young women who are single and pregnant. So are there other groups that you would like to comment on as far as who might be at risk in this setting, and how you look at all these different groups and how that influenced the choices you made in the design of your approaches or in your research, and who you may have included or not?
I can start us off. So as I had mentioned, we target our intervention for a group of in-school VYAs and a group of out-of-school VYAs. And as we started, we realized that segmentation is overly simplified. So even when we're working with the in-school groups, we know that there are different types of schools. Each type of school requires different approaches. And we assume that there are some different kind of levels of vulnerability in terms of whether a student is enrolled in public versus private school. But for the out-of-school group, it really is much more complicated and kind of deserving of further thought. So we chose to work with out-of-school young people, out-of-school VYAs who are still living with a family, as opposed to those who are street dwelling or who are living in some sort of institution. And we made that decision for a couple of reasons. So first, because we realized when we went out to the communities and we saw the situation, we realized very quickly that street-dwelling young people in particular are going to have basic needs that are not being met and that are not going to be addressed through an SRH intervention. And we felt that there were some logistical and ethical challenges in that. And then also for the purposes of our work, because it is being evaluated longitudinally, we really worried about the ability to follow a cohort of young people over time. And so as a result, so when you see these communities, you can assume that all or most of the children who are living in these communities are by nature vulnerable. But because we're working with those who are in school and those who are out of school who are still living with a family, in a way, we're kind of reaching the lowest hanging fruit of the most vulnerable in these communities. And so there are other segments of young people that we really need to think about how to find them. So if there are no existing platforms, how do we bring them together? What are their reference groups? So who is shaping their norms and their practices? And how do we develop and adapt interventions that are meaningful for their needs? And then the other group that I didn't mention is that Kinshasa is a huge city. It grows by an estimated 400,000 people every year, and a lot of that is migrants who are coming from the conflict-afflicted parts of the eastern part of the country. And so you have people who are coming from very far away, who don't speak the same language, who are coming from a very different context, and who are potentially dealing with the trauma from having left this conflict. And so we have a number of different subsets of adolescents, even of VYAs, who have a lot of different needs, and we'll have to really think about how do we identify what their needs are so that we can adapt our interventions accordingly, and how do we find or how do we put in place appropriate platforms to meet them.
Thanks, Lonnie. Yeah, I think so. When we first started CyberGirl, we went in with the intention of designing this for urban Rwandan girls. And so it wasn't until the formative research, when we were speaking with over 400 youth and their beneficiaries, that we saw that we were speaking to orphans, domestic workers, sex workers, university students, out-of-school students. And it's like, you really need to heavily invest in that formative research process and allow for that segmentation to really unveil the internal diversity of urban youth. And it wasn't until we did that we really had to reframe the way we thought about our intervention. It could not just be a digital intervention, because these different segments of young people have differentiating access to technology, to information, to education. And what was shocking for us is that despite these differentiating levels of access to education, pretty much cross-cutting across all of these segments, we found that they all had shockingly low knowledge of reproductive health and menstruation and puberty and just basic understanding of how your bodies work. So it didn't matter if you were a university student or a domestic worker, your levels of knowledge were pretty much the same. But what it did encourage us to do is to reflect about how we can start to incorporate ways of providing the same content on non-digital platforms in order to sort of have that equality of access for all youth segments in our intervention.
Just to build a little bit, I definitely agree with all the sort of subgroups that were already mentioned. And I definitely think the single unmarried group is one that in urban settings might be particularly important to target. Also, I think those who have complications in pregnancy, again, this just points to the need for more research and disaggregating data, perhaps data sets we already have, or in the future to make sure we kind of segment how, or at least able to typify who's experiencing what and see what the follow-up to that type of condition may be. For example, if a young woman developed preeclampsia, what was her pathway to care? And how is that different in both urban and rural settings? And then within urban settings, maybe segmenting within age groups within the adolescents. So those who are delivering as very young, younger adolescents compared to those who are delivering between 18 and 21 years, for example. I also think it would be important to look longitudinally at some of the programs to see how sort of the SRH educate this, whether it's a multifaceted intervention, how these things pan out across the life course for different segments, whether it's a migrant or someone else.
Thanks. So I want to pick up on your point about, there really is a greater need for more research, and also Nicole's point about how shocking it was to see that across all of these segments there was so little knowledge or information that that the adolescents had about, their physical processes and their bodies. So I'm wondering, as you were engaged in all of this work, recognizing that there tends not to be a huge amount of research on urban adolescents, and generally urban poor and marginalized populations, broadly speaking, are considered to be a less understood group relative to those we often work with in rural areas. I'm wondering if there are other things that really surprised you about what you were finding as you went about this work, and whether you had any assumptions that were really turned on their head as you went about this. And I think, Nicole, you really touched on this as you got into where you started and how that process evolved. But I'm wondering if there are other things you want to comment on in that regard.
Yeah, I mean, I think that sort of, at least in my experience, sort of historically in development work, we have two buckets. We have urban and we have rural, and then we have very strong preconceived ideas about what it means to work with urban youth. We assume they have better access to education, better access to resources, better access to, employment readiness, and especially for a place like Rwanda, which is having tremendous economic growth and huge strides in development, we would assume that, urban young people would be better off. And I think that what was very shocking for us is to find that, no, they are systematically being left behind, and that unemployment is highest among urban girls in Rwanda is shocking, that their access to technology, despite the technological boom, is mixed and varied. And so I think that it's difficult to challenge these assumptions about how we conceive of urban adolescents and maybe some of the advantages that we think that they have. I think that we have to come in with a fresh slate and just sort of take it from there in terms of understanding, like, maybe there are some unique vulnerabilities that they have that we hadn't thought of before, and sort of starting from there.
Okay, so switching gears for a moment, a couple of you mentioned technology and media in your presentations, and I know that with regard to urban work in general, it's often, we note a lot of challenges and how different it is, but quite often there are certain advantages cited, such as greater access to technology and media. So I'm hoping you can speak a little bit to, one, how you're able to capitalize on that, but also some of the risks and pitfalls associated with that.
I can go ahead, yeah. So a couple of things. I think sort of as you saw, our initial design was a mobile app. And I think from what we've learned in a couple of our programs is that an app is not a panacea to development work. It's not useful to create new apps. It's better to engage youth on the platforms with which they're most familiar. So that could be social media, it could be Facebook, it could be WhatsApp, to really leverage those technological platforms which they're already engaging. They're comfortable using their own data plans for that, or they're built in. They don't have to use extra data for that. The advantages of using technology is that it does provide a trusted, confidential platform to disseminate accurate information. And this is really important, particularly in environments where there's a lot of stigma and taboo about discussing reproductive health, family planning, or sexual health more broadly. I think sort of the other thing that is pretty helpful about it as well is that, and this is a little bit controversial, but in our very important work of trying to create youth-friendly health services, we have to recognize that service providers they're part of the community. They have one foot in the clinic and one foot in the community. So they have very strong biases that will be very difficult to address over time, and it does take time to do that. And in our work of trying to address those provider biases, we need to still create mechanisms and platforms to still be able to disseminate reproductive health information to young people. And technology is a really great way to bypass the biases that are so deeply rooted in these communities.
I can just touch a little bit more. I agree that I think that technology can be used in effective and sort of not so effective ways. One example of, I think we need more sort of implementation research about how some of these technologies are functioning. Similar to the app, there's another app that right now Population Council is testing some of the effects of. It's a similar digital platform for women to access reproductive health information, family planning services, to kind of see, it sort of gives you information. It's customizable to the user, so it uses SMS as well as interactive voice response for women to be able to ask and answer questions about where to go and what types of care might be, what types of family planning methods might be better or worse, or what to ask your provider when you get to the facility. And during the pilot phase, about 25% of the users were under 20, and so right now the platform, it's called Nevi, has been live for about a few months, and so we're hoping to see how that can be segmented and understood better across different populations. So I think that's one way to tap into how effective these technologies are in youth, because I think youth are the early adopters of a lot of technology, like cell phone usage. So I think that would be interesting. I also think it's important to consider the women who do not have access to phones, and that often limits how well these interventions that use mobile platforms can kind of get out there. And so to have a combined approach with community-based strategies would be important.
Thank you. So I just have one final question, and then we'll open it up for all of your questions. Melanie, I know that the project that you described really focuses on gender and social norms. So considering that this project was adapted from a rural context to an urban, I'm wondering if you see differences comparing those when you're speaking specifically about the differing needs between boys and girls, and if you could speak a bit about that.
Yeah, I mean, we're seeing a lot of similar gender norms across contexts, as far as education being more important for boys than for girls. We see a lot of norms about how, girls, there are more restrictions on girls' movements, especially due to safety concerns. But, I think one of the gender-related issues that has challenged our assumptions, or that has been a little bit of a surprise and an implementation challenge to us, is really just around availability. So we know that when we want to start challenging gender norms, we have to have both men and women and both boys and girls at the table to have a productive discussion. And, when we see the girls are not able to leave their homes and participate in sessions, or when they come, they're distracted because they have to care for younger siblings. That's a challenge. And then at the same time, we know that especially around the norms and the practices in place at the household level, fathers are really important. And so, often it's the father who says, "No, I don't want my son to wash dishes," or "No, my son will go to school before my daughter does." And when it's difficult for us to even just find ways to engage with fathers, since, like I said, they're traveling and they're busy, and often they're not living with their families. It's been challenging to find ways to even just have that discussion in a meaningful way. And I think that there are different access-related challenges with gender in a rural context as well, but in the urban context, we're finding that often, especially with the fathers, they're not around or they're not available, which is really, really challenging.
Thanks. And I realize I directed the question to Melanie, but if Nicole or Pooja, if you have anything to add, please feel free.
Well, I think I sort of touched a little bit about this, but we initially designed the Cyber Girl Rwanda for girls. And then again, during our formative research, we found that boys have just as pressing reproductive health needs as girls do. And in fact, it was alarming. Even one boy said, actually quite a few of them said, "We don't even talk to our friends about sex." It is the most repressed and stigmatized environment I've ever seen. And it was alarming to see that, and this is why I think boys in particular really depend on internet and porn for their sexual information. And so I think that really, taking a more tailored approach to our programming and understanding that boys need this information just as much as girls do, and that, boys are the primary decision makers when it comes to contraceptive use and family planning and family size. So it's really important to be able to engage boys in this program as well.
And as you saw from some of the examples, that definitely came out in the younger male partner group. And actually, it was interesting that there seems to be a cultural shift. We did a focus group with slightly older men, and their clear answer was, we don't want to be involved with maternity, whereas the younger males were definitely more engaged. And so that's promising and interesting. I also wanted to sort of note the issue of gender as more of a power dynamic. So in addition to just male-female, when you think about adolescents seeking care at facilities, there's already a gendered relationship between patients, women, and providers, any woman and a provider when she's going for maternity care. And so that might be exacerbated when you see an adolescent who maybe has even less agency. So.
Great, thank you. And I note that Nicole's comment toward the end almost answered the previous question as well, as far as risks associated with greater access to media if you're dependent on internet and pornography for all your sexual and reproductive health information. So that probably warrants a discussion of its own at some point. Okay, well, I think we've got ample time for discussion and questions among the group. So maybe what we can do is take maybe 2 questions at a time, and then the group will answer. So we can open it up now.
Thank you very much. I'm Mark Hathaway from MCSP Japigo, and I'm thrilled with all the presentations. Thank you very much. Big congratulations to you, Nicole, for reevaluating and rejuggling and getting your donors to help you do that, because that's big to reshift something after you've spent time. I'm kind of curious along those same lines of, you mentioned that you were engaging boys, thinking about boys. Was there any thought, or is there any thought to developing a Mutoni boy?
Yes. So, sorry, should I wait? Sorry.
Do we have another one
I have another question that's somewhat unrelated. I didn't note that any of you mentioned, I don't think, abortion. I'm kind of curious of what what adolescents thought of. Did they bring it up? Did they discuss it? Did it get discussed at all? Thanks.
I think we can go ahead since we've got 2 questions. No.
Is it possible to bring up my... Yeah, so we do have an avatar, Natwali, who is for boys, and the boys did design him, and so they will be they'll be receiving the same amount of the same kind of nature of content, but it will be geared for boys as well. So I just wanted to flip through and find it. But yes, we did start to prototype with boys in addition to girls, and so they were able to create their own avatar, which they will be receiving. If you can keep going, yeah, towards the end. Keep going. Yeah, that's him, Natwali. Yes, he's slightly older looking, as they had asked for. He has a little bit of gray hair on the side. By design.
Okay, so we have 2 questions from one of our participants who's engaging in the discussion remotely. I'll read one of these. We'll take them individually, I think. So Julie L. At Colorado State University has asked, in searching for ways to diffuse gender-equal norms and raise awareness about reproductive health, are there opportunities for building partnerships with influential community actors that might be well-positioned to encourage gender-sensitive normative transitions? And I'll read the second one. And she also asks, given restrictions in mobility and low levels of attendance by the broader community, are there ways to incentivize engagement to increase participation in reproductive health programs?
So I can take the first, and I will take that question if you don't mind. So I think that there needs to be a strong community engagement component to addressing social norms, and we've started on that road. So we work through a network of community protection volunteers who facilitate activities with kind of community members broadly. So they use an adult version of the game, and they hold video sessions with community members. But as we've gone forward, we've learned a lot about how we need to be kind of precise in who we're targeting and who we're engaging. And so as Julie said, we really need to figure out who are the influential community members and who's kind of shaping the social norms. We did an exercise, a social norms exploration tool that we developed with our partners, and we use that to kind of look at who are the reference groups for very young adolescents and for those who influence them. So especially their parents, and that was how we learned about how influential neighbors are. And we also learned about how a lot of parents are heavily influenced by members of their church and by the church leadership. And so I think that's definitely an area for further work, is really understanding who is influencing the norms and the practices of VYAs and their influencers, the parents, and finding appropriate platforms and messages to engage those people. And I think, it's kind of similarly to Nicole's point about, needing to think about the community around health providers. I think maybe we need to think about having like a 3-dimensional socio-ecological model, because it's not just enough to think about who are those who influence our target group in the middle, but you have to think about who is influencing every level of those who are influencing them. And so I think a 3D model would be something interesting to explore.
We did speak with quite a few additional stakeholders. In addition to youth, we spoke to service providers. We spoke with parents, which is the most critical, I think, influential stakeholder. And I think, again, back to the point about how you frame the program to make it more acceptable to this influential group, which is that you have to frame our desire to really have a program that has comprehensive sexual health information as a means towards ensuring more economic potential for their children. So pregnancy prevention as a means towards safeguarding their entrepreneurship potential. We spoke with employers to understand what kind of skills and tips girls would need to make them more marketable in the future. We spoke to service providers to understand sort of what their barriers were to giving girls certain hormonal methods. They had very preconceived, deep biases about what kind of girls would qualify for these long-acting hormonal methods. So this is, I think we took a lot of that into account when we were started to redefine the way that we wanted to structure our program.
And since I didn't do as much of a programming perspective, but I do know that community dialogues, based on some other based on the broader Respectful Maternity Care prop council work, were really, really effective. And so I would think that when you target adolescents, it's important, again, to use these contexts. I know Karen Austrian's work on Adolescent Girls Initiative in Kenya actually did that, and that was really effective in slum areas. The other thing I wanted to mention in response to the abortion question that came up earlier, that definitely came up. I'm not sure if you saw on one of the slides, the providers brought up abortion as one of the challenges, one of the key challenges, that and HIV. So in terms of actually clinical management, and with adolescents often hiding their pregnancies and sort of trying to seek different services but not being open about what they want, and that came from the provider perspective. From the adolescent perspective, we didn't probe specifically on abortion, but I think if we did, we'd definitely learn quite a bit about that. So I think that that's definitely a concern. The broader political sort of legal issues in each country need to be taken into account, and that often colors what people say. And so that, I think, limited the amount of abortion information we had in the quotes themselves. But yeah.
So we do have the second question here on incentivizing engagement to increase participation. Do you have comments on that piece?
And this is another plug for human-centered design, but this is this is what's remarkable about the process, is that you go in with this understanding of this is what youth needs are, but you also get a better sense of what their aspirations are and what inspires them and what the reality of their lives are like. And so because of that, we were able to really uncover the fact that, what youth really want is employment opportunity. And they want to be set up for success in that way. So health is not always the key concern for them, right? But their economic futures are, and it's a failing point in development that we silo too often economic opportunities and health training, right? We and I think Melanie, you touched upon this as well. We need to be better about integrating those two sectors, because you can't get a job if you don't have good health. And if you don't have a good health, you're not going to get a job. So we need to be better about integrating those two. And I think that's what really incentivizes participation in these kind of programs.
And I would just add, from our experience, we're not necessarily having trouble incentivizing VYAs, because, the activities are fun and they're engaging and they want to come and they want to be involved. The challenge that we're having is with getting the parents to participate, because they have a number of competing priorities. And I do think that there's thought to be put into Nicole's point about how we integrate the work with health and livelihoods. And that's something that Say the Children does in our programs for adolescents. I mean, we're developing an integrated adolescent sexual and reproductive health and livelihoods curriculum, but it's for adolescents. And so I think maybe that's an area for future thought, is how do we integrate, how do we reach parents with information about sexual and reproductive health, and also with information about their child's future livelihood and education opportunities. And again, to Nicole's point about making sure that we understand the needs and the interests and the values of the parents, so that we can design appropriately.
And I'm wondering if that question takes on a different dimension when we're specifically talking in the urban context, where there is a cash economy, to the point about livelihoods, but also as far as engaging adult stakeholders and parents, where you're talking about, where there are different dynamics as far as mobility and security and employment dynamics that make time sometimes the most precious commodity that people have. So it's an interesting question. Do we have other questions in the audience here?
So I wondered whether you could talk about whether you've encountered any resistance from religious communities, for example, in urban areas. And I know recently here at the Wilson Center, we had Joyce Bond, former president of Malawi, here with us. And this was a specific focus of her research while she was here. And she very often spoke about the difficulty of dealing with chiefs in the rural areas and sort of customary beliefs. And I wonder how that plays out in an urban setting. So I wonder whether you could talk a little bit more about barriers, resistance, and sort of how you manage that in an urban setting.
That's a great question. So I think it's a little bit different in urban settings. I will say that we have a very strong implementing partner that we work with in Rwanda, SFH Rwanda, which is a PSI affiliate, and they have strong ties to the community. They work in schools, they work in health centers, they have strong connections to the local government. And I think because of that, because of all of the time we spent over a year, doing this kind of research on the ground back and forth. But I think that because of that, we didn't face as much resistance from religious communities as perhaps there would have been in rural areas. We do have a very interesting religious diversity within our youth segments. So it's quite a heterogeneous group there. But I would say that that is not, from the religious community is not exactly where we met resistance, which is pretty interesting.
I would say that in our experience in Kinshasa, we haven't been encountering resistance from the religious community either. When we talk about our intervention, when we talk about getting parent permission to participate and permission from schools and teachers to incorporate this information, we always have to be very careful to talk about how we're providing age-appropriate information for very young adolescents. And that information is, information about their changing bodies, and we provide information about health services and some information about contraception and HIV, again, that's age appropriate. And so a lot of it really depends on kind of how we approach it. We are finding that in some cases, we need to think about kind of reversing our order of operations. So instead of first thinking, well, how do we reach the very young adolescents? We need to think, how do we first engage their parents and their adult caregivers? And I need to be careful not to always say parents, because so many VYAs are living in a home with not just their parents. But in a lot of cases, in all cases, we need to have that parent and caregiver permission and sign off before they can be involved. And so we have to think about how do we present the information and how do we present the intervention in a way that addresses their concerns and that it makes them feel that this is worth their children's limited time and their own limited time to participate.
Thanks. Winnie.
Thanks all for those very interesting presentations. Given the need for adolescents to seek care from places that don't need to be dictated, I was wondering whether, and this is maybe targeted to the Kenya and Kinshasa examples, to what extent you've engaged private sector? Was any of your situation analysis was any of the research conducted with private sector providers or informal sector that are more likely to be sources of services for urban settings?
So in Kinshasa, our work itself doesn't have a service strengthening component. We did a separate assessment to look at the quality because we wanted to know, we wanted to make sure that we knew how to build those health facility linkages for future use. And we're mostly working through the public sector. But we do know that in Kinshasa, as in many urban contexts, a lot of people are seeking private health services, and they're also seeking services from the informal health sector, and they're seeking services from chemist shops and other informal places where there's no regulation of quality or safety. And so we definitely know that as adolescents get older and they transition into the later years of adolescence and they become more in need of sexual and reproductive health services, we need to make sure that they have a wide range of high quality services that are available. And we also have to think about that privacy consideration, that's the most, for a lot of adolescents, that's the most or one of the most important factors for their decision to seek services in any way, is the ability to do so discreetly. And so sometimes the private sector is a good alternative, and sometimes those informal delivery points are another option for ensuring that they're able to seek friendly services discreetly.
And from the Kenya context, definitely the broader study conducted research in both public and private facilities, as well as faith-based non-for-profit facilities. Within the sample, we did ask sort of a question, just a questionnaire point of what the community's preference was, so what the woman or the man's preference was in terms of facilities to deliver at. And the majority did say public, but there were sort of a small proportion that said sort of a third, maybe less than a third, or 25% or so, say that they prefer private. And I think that needs to be further, that disaggregation needs to further happen. But I think there's still a preference in more of a sort of who do you trust perspective, that it is the government sector in this particular setting, yeah.
And was that particular to the adolescents or
This is within the adolescent sample.
do you know if that was distinct from
That I need to go back and check, but yeah.
Sure.
Thank you. I wanted to ask maybe the other side of the coin to Roger Mark's question about faith communities and not just potentially managing resistance from faith communities or influential faith leaders, but actually proactively involving them in some of this programming. I'm with World Vision, and we actually have several very successful examples of education efforts that directly involve faith leaders in healthy timing and spacing education, and even to the point of incorporating messaging about family planning into sermons. So really seeing them as not just potentially managing resistance, but actually using them as champions and educators as well. So just from your experience, if in any of the programs you've worked on directly or those that you work on, how those partnerships maybe have been created and encouraged with the faith community.
So not with this project, but I actually just came back from spending the summer in Niger, working to increase support for reproductive health activities among religious leaders in 10 different villages in the Zinder region. And it was a remarkable experience because, sort of as you said, there's this very influential group that can be leveraged in each village to promote birth spacing and promote family planning. But I think that there are some challenges sometimes about there's not very consistency in the ways that they interpret the Quran. And so because of that, I think that things like inserting, advocating for birth spacing in their sermons is a positive thing, and being able to tie it back precisely to where in the Quran it might say that women should, families should not have more children they're able to allow for or that they're able to take care of. And also the other thing that we did is that working with religious leaders, trying to improve their relationships with young men in the community, and also tapping into what is aspirational for young men. So in the context of having so many children, I think the average TFR in Niger is 7 point. Thank you. It's a good group. Yes, it's the highest in the world. So understanding what exactly is driving these young people to have such large families if they can't take care of them, right? And so we did a lot of interesting research and programming around that, but I think that involving religious leaders was also tremendously helpful in doing that too, because it's norm setting, right? And it's addressing or reversing these norms that say that have as many children as you can, because that's what Allah would want.
Other questions? Yep, let's go up front here.
So just learning about how people or kids are actually learning about education is through porn, and not to say that anybody should promote porn, but I think or to create porn, but I think is that like some way you can make it a vehicle for education, not porn again. But however that's getting distributed, but having, I don't know, but like using something that's already there, I guess, and maybe not porn, but any thoughts?
I will say one thing that we've thought about is that we need to, when we go out into communities and we work with adolescents, we find that they're often sharing porn, through the little chips on their phone, the SIM cards.
Yeah.
And so I think that there are actually lessons that we can learn from the way that porn is getting into the hands of young people to think about, well, how can we put our messages into the hands of young people? And then the other thing that we have to think about is, we have to acknowledge porn when we're talking, when we're providing comprehensive sexuality education, when we're working with VYAs and we're talking about puberty and sexuality. We have to acknowledge that kids are watching porn and to talk about it and to talk about how it's not realistic and how it may not be an accurate or a positive depiction of adult sexuality. And it has to be something that we need to think about, and we need to acknowledge that this is a big vehicle for how kids are getting information about sexuality.
Yeah, I don't think I could have said anything better than that. It's pretty great.
We had a question back over here.
Thank you. This could be directed at anybody, but maybe more Melanie. I'm curious about, you were working with the schools in some cases, and I'm curious what the thought process was of how early it's okay to talk about sex education, and what the schools, was there resistance from the educators in the school systems?
So I can only speak to Kinshasa in this particular case. The DRC actually has a national family life education curriculum that starts in the pretty early grades of primary school. So we didn't face a lot of resistance. And in fact, a lot of the teachers were really welcoming of the fact that we're bringing in kind of interactive and interesting materials that they can use in their classroom. So in that context, it's been really welcomed. I know that in other contexts, both urban and rural, we faced a lot of resistance where teachers are not comfortable talking about this information, where parents are not comfortable having it placed, having their children exposed to this information. And again, I think that starts, it comes back to the question of, we have to really lay a lot of groundwork before we can go in. So we need to build those partnerships with the school and build partnerships with the parents and adult caregivers before we actually go in and provide information through the schools.
So I'm conscious of the fact that all of our questions have come from the front of the room, and I'm worried that's because my vision is terrible. So are there questions from anyone in the back that I've been ignoring? Sure.
Hi, so my question is for Nicole specifically. I think at the end of your presentation, you mentioned that you had spoke to over 300 or 400 beneficiaries at the end of the project. I just was curious, how long did it take before you actually started implementing? Because I think like there's, youth engagement is very important. I think that having, the more youth are involved, we know that it's more likely the success of the program, so I'm just curious.
It's a great question. So we did about 3 or 4 months of formative research, and then based on those findings, that we moved into 2 rounds of prototyping, which is basically like testing out those avatars and testing out the design and content with our users. And then we also we trained youth designers in Rwanda on the whole prototyping process. So that the prototyping sessions were actually, one was done, in the field with our team, and then the rest of them were done remotely because the youth designers were able to lead them themselves.
Hi, my name is Allison Garland, and I work here in the Wilson Center's Urban Program. And I was just wondering, I'm thrilled to hear these presentations, and I was just wondering how your work has been received sort of in the development community and the donor community working in the urban context, and if you've met resistance to this work, or if the donor community and national governments are open to the idea and recognize this need to do this work, and especially research in urban areas, and I'm also interested in the peri-urban area, how you see doing this work and research is different from working in cities, but working beyond that into the peri-urban.
Great question.
I can start. I think that I think you're definitely right that sort of urbanization and studying urbanization and urban health and maternal sexual reproductive and maternal health in these settings it's not fairly. I think people have been doing it. I think there's actually a movement now towards looking more at these issues. I think there are challenges that we know still continue and persist in rural settings that need to be addressed, but I think there is sort of a shift towards understanding how things like quality of care affect are maybe even more influential in urban settings where there's a range of choices. And so there's also the mix of, as someone mentioned, the private sector, there's just much more of a heterogeneous care delivery like service delivery sector. So that I think is at greater play in urban settings. I think I hope will be more work in both peri-urban and urban settings around this topic, and both in terms of adolescents, but in general. But I do think youth, especially migrants that are coming in, would be important to look at further. And I do hope there's more funding towards it. But yeah, I think comparative work might be a place to start, so that can start to build an evidence base that may potentially be used or leveraged to get more interest.
Yeah, Pooja, and I just wanted to build off what you were saying, because I think there's an appreciation in the donor community right now that what we conceive of as urban communities are not actually so urban anymore. And because of migration, whether forced or voluntary, we're seeing an influx of people who are coming in from rural areas, or they're coming in or they've been displaced and they're resettling in these urban communities. And it's actually a very intensely vulnerable populations, because they've left their homes, they've left their jobs, they've left like their familiar environments, and they're trying to put in new roots in a very urban, rapidly changing communities. And so to be able to address those particular needs is very important work that I think is having quite a bit of resonance in the donor community right now.
I think we have time for one or two more if we have other questions. Okay, I see 2 questions, so maybe we can do those.
Hi, I'm Charlotte Warren from Population Council. Just to build on the response to your question about what's been done research specifically, APHRC in Nairobi have done a longitudinal study on urban access in the slums in Nairobi. And so there is data already out there. And then one of our colleagues in Poverty, Gender and Youth program within Pop Council has wrote a book a couple of years ago called Girls on the Move, and it's looking at girls moving into urban areas and the challenges that they face. So I think there's quite a bit of research out there, but not enough. But just to add those, and then the other one in Nairobi that Pooja mentioned, Karen Austrian has done this safe spaces, and then introducing financial literacy to girls in urban areas, and that safe spaces model has been replicated in a number of countries. So I think there are lessons learned from those on how to reach young adolescent girls specifically.
Thanks for that comment. As we're getting to the next question, just to say thanks for highlighting that important work. And I know the Girls on the Move report as well highlights the importance of urban to urban migration, which perhaps gets less airtime and things like this. So just to pull that out, it's a great report.
I'm just kind of curious about bargaining with patriarchy. Sometimes the worst enemy is the mothers, the grandmothers. While you were talking about getting the families involved and seeing their point of view, what is the influence? I mean, particularly I can see, when we talk about migrants from rural areas, but also, is there something about mothers deterring their daughters from seeking birth control?
So from our experience in Kinshasa, and again through that some of that exploratory work that we've done, we found that often mothers are coming from a place of wanting to protect their daughters, and we see this in places around the world. And so they're wanting to make sure that they're not exposed to information that could potentially put them at greater risk, and they're wanting to make sure that they're not exposed to individuals or to activities that are putting them at risk. And so there is kind of this intense fear that your daughter could become pregnant, and it can derail her life trajectory, and it can put the family or bring shame to the family in ways. And so I think, as a manifestation of that, we do see this kind of control from the mothers over the information that comes to the daughters and the restrictions on their movement. And it really, again, just really highlights the importance of understanding who is influencing the influencers. So when we know how influential mothers, and then as girls get older and become women, mothers-in-law, we need to we know that they're heavily influential. We need to understand really where they're coming from and who are their reference groups and what are the norms to which they're adhering, because they really are so critical at so many different stages in girls' and women's lives.
Thanks. And we'll take the last question up here.
Diane Seeger, what is the impact of religion or religious groups in decisions, especially abortion, but religious education for young women and men, boys?
Well, I can maybe speak to at least the influence. I can definitely see that sort of the influence of religion. The context we were in was predominantly a Christian setting for this work, and I recall one of the young women saying, I was trying to remember, I can't remember the exact phrasing, but in the context of abortion, mentioning that when she got counseling about her pregnancy, and I think she was seeking care for abortion, but saying that the provider was good because they were counseling her to not so I think religion colors a lot of how adolescents approach providers and what they can talk about and what they can't talk about when it comes to sexual and reproductive health. So I think it gets to sort of how the religious norms and what they're exposed to at a young age. So by the time they're pregnant, whether that's a 16-year-old, 17-year-old, how they even are able to articulate themselves, it definitely plays a significant role. And I think that in order it affects what they can and what types of service quality they can get, and whether or not they can maybe even trust their provider if they're sort of they're judging their responses in a particular way, and the providers are judging what the patients are saying in a particular way. So I think it really does have an impact on the care service delivery interface.
Thanks. I think in the interest of time, we'll wrap up here. Before I turn it back over to Roger Mark for his concluding remarks, I just want to thank our panelists for their excellent presentations and the engaging discussion. I'd like to thank all of you for coming here or tuning in remotely during a holiday week. I know it's busy, so thank you. And particularly, I'd like to thank, since this is the third in this mini-series we've been doing on urban maternal and newborn health, I'd like to thank the Wilson Center for their collaboration and the Maternal Health Task Force for their collaboration during the series. So thank you very much. I think the presentations today have highlighted a number of points, the critical importance of paying attention to the needs of adolescents in urban settings, including with regard to maternal and newborn health, approaches for engaging with this highly heterogeneous community, and having a discussion and contributing to the discussion on what works as far as reaching these populations so that we can begin to build evidence and a body of knowledge around how we address these problems and the needs of these populations, and demonstrating that these problems are not intractable. So thank you. And I'll turn it over to Roger Mark for his remarks.
Thank you very much, Lani. What a great way to kick off a holiday week. A lot for us to think about. I think we once again started by contextualizing why at this moment in the age of the city, as we mentioned, it's so important for us to focus on adolescents and young people in an urban setting. And as we think of what we have done in terms of rural programming, how is that different? We talked about the advantages that we might anticipate in an urban setting and testing some of our assumptions in an urban setting. We specifically looked at a number of the risks and then looked at the different characteristics of the target population in an urban setting, specifically recognizing that they're not homogeneous. I was pretty pleased that we were able to talk about this in the panel by looking at different age cohorts for this population, but really understanding the complexity in doing that segmentation. We talked about working with young people who are in and out of school, who are operating in an urban or peri-urban setting. We talked about having access to different kinds of networks and family support structures, or being in and out of church and what that meant. So there was a lot more sophistication, analysis, and segmentation that needs to go on as we think about specifically reaching those populations. I really liked that we had a number of key insights that led to some areas for us to focus on. We looked at things around sex education not being very practical. So really looking at how can we have practical dimensions to that. Providers who are not necessarily presented as trusted advisors, how do we move towards that? The importance and the need, once again, for a safe space that kept coming up. And this compelling point that regardless of how we look at this population, that there is a core need for information about their bodies and what's changing and what that means, so that it increases understanding and decision making. The important point about linking any target interventions to questions around financial well-being, livelihood opportunities, entrepreneurship as being very important, and yes, involving boys and young men. So good to see that coming up again. Some of the innovations that I thought I saw, once again, was this holistic programming in terms of how we provide housing, protection from harm, this entrepreneurial perspective. I think that came up a number of times. We talked and had a number of examples, I think, in terms of innovations around video discussions, games, apps, but also not just relying on digital, but also thinking about the non-digital that complements that, particularly if you're dealing with individuals who may not have access to technology. An important focus on driving the user needs involvement. Quite revealing that they said this app that you're presenting is a little too polished for us. We want to be involved in it too. Don't present us with this finished product. Who you're presenting for us, this avatar, is a little bit too much of a pair. We want to aspire. We want to be inspired, and we want to aspire to something. So I think that was an important finding. The use of colors, white wasn't a good choice here. So, white associated with death. Not the message that we wanted to convey. So I think important point about this human-centered approach and user needs. Also a number of key points around trust and trust networks and what that meant in terms of the different types of pairs and who they wanted to see in the birth preparedness setting. Also, I think a number of questions came up for us. Who's influencing the influencers? Well, how do we lead to different types of incentives? How can we continue to engage the corporate sector and the religious leaders? And how do we deal with these set of questions in an urban and a peri-urban settings, and recognizing that there are people moving in? So there's a lot of, it's a very dynamic environment, but I think we all came away with an affirmation of the importance of systematically looking at this and a willingness to continue to test, fail, pivot quickly, engage. So, wow. What a way to start a week. So thank you very much. You know, for us, this collaboration with our partners, with folks that Save the Children, is amazing. As I said, you make us look good. This is really wonderful. We're really delighted that we had folks engaged online. We had questions that came in online. This was webcast live. It has been recorded. We will video archive it, and we will provide a written summary of the discussion today. So you will have a video archive, you'll have the presentations, and you'll have a summary of our discussion today. I particularly would like to thank my colleague Sarah Barnes, who took the lead in pulling this together, and a number of colleagues who are also in the room. So keep coming back to the Wilson Center with colleagues and a panel like this. It's just great stuff. So thank you.